Wonderful. Thank you so much, Rachel. Good evening, everyone. Thank you for making time. I know everyone's had a long day. Our goal is to make this a 40-minute presentation. Go ahead and interject, interrupt me, ask questions, and we will reserve time at the end to ask questions as well. The title of the talk today is Using What is New in Pain Medicine for Your Patients, bringing a little bit of tomorrow into today. Next slide, please. So pain management, I'm sure I'm not the only one who used to conceptualize pain this way. That's very dour mood. People are looking at the clock. When can they take their next medication? They're in bed all day. They hurt just to shift positions on the chair. And that's what I thought pain management was until I learned about some of the things that I'll share with everyone tonight. Next slide, please. This is something we all know, the opioid crisis. I'm not going to belabor this point, but we hit a peak 2010, 2012. Since then, the graph shows that we're going down in the opioids prescribed, the morphine milliequivalents. So it begs the question, where are we going? What is the next step? And the talk tonight is to give you a little bit of information of those exciting next steps that we can offer patients, your patients, to get them off opioids, to get them pain relief. Next slide, please. Really quickly, for people who kind of conceptualize pain medicine the old way, I fully acknowledge that the old way is kind of opioids, and some more opioids. The new way is this multimodal therapy, minimizing opioids, interventions, using them to lower opioid kind of use. The old way is basically anyone who took a weekend course. Now there are stringent guidelines, board fellowships, board certifications. In the past, it was epidurals, and epidurals as well. Now we'll talk about spinal cord stimulators, interspinous spacers, peripheral nerve stims, nerve ablations of basivertebral nerve. So lots of exciting things. And next slide, please. And a little bit of a story, so kind of contextualize this a bit. So this is in France, and the gentleman on the bottom right is my father. And we grew up in the Midwest outside Chicago, and my father was walking the dog. This was right around this time of year in December, and it was dark out, and a car was pulling out, and the car didn't hit him, don't worry. But he kind of pulled our dog, a little bit off the sidewalk. And when he did this, he rolled his ankle a little bit. And from that point on, he developed a very common neuropathic disease. And unfortunately, at the time, he wasn't aware of these therapies. I wasn't aware of these therapies. Well, he got connected to some of these therapies. He got connected to physicians who knew about them. And then lo and behold, many years later, we are walking in France here. He's smiling. He's enjoying the sunset here. So this is going to happen. I've seen it with my own family, and I'm confident that we can offer this to our patients as well. And we'll learn a little bit about the ways. Next slide, please. Financial disclosures, the obligatory. This is my wife. She's at the bottom left. She is a primary care physician at UCLA. UWorld, I founded a software company when I was in medical school, and I sold it when I was an intern year. It was later acquired by UWorld. And then finally, Thalamus is a residency interview platform for residents and fellowships. I'm an early investor as well as a content creator as well. Next slide. A little bit about me. I'm double board certified, like Rachel said, in anesthesiology and pain medicine. I'm also a pharmacist. I'm licensed in California. I practiced for 6 years. I like to say abreast kind of in the current knowledge. I wrote the opioid chapter in the Manual of Clinical Anesthesia. I wrote History of Peripheral Nerve Stimulation. I was with the FDA Office of Generic Drugs, and I served as the chief wellness resident at Stanford, and I reviewed a few things for the Pain Medicine Journal. Next slide. And most importantly, I'm very honored to be part of Los Robles, and all of these cases we'll be talking about can be done at Tosh, so that is very good news. Next slide. A little bit more about me, like Rachel said. So I'm an associate interventional pain at SCOE, very honored to be part of the group. I have offices in Simi, Porter Ranch, Thousand Oaks, and Van Nuys. I also hold appointment at Stanford as a clinical instructor, and I'm also the podcast host for Pacific Spine and Pain Society. Next slide. My training, so I did my pharmacy training at Butler, Indianapolis. If anyone is familiar with college basketball, I went to both their championship games. I did my medical school down the road in Irvine. I went up north for training for anesthesia, and then I came back down to LA for my pain fellowship at Cedars. Next slide. And these are the kind of things that I hear when I talk to patients throughout the day. So I was told by my mentors at Butler, if you shut up and listen long enough, the patients will tell you what's wrong with them. At Irvine, Dr. Wynn told me, no one cares how much you know until they know how much you care. At Stanford, Dr. Barrett Larson told me, make tomorrow happen today. And finally, Dr. Howard Rosner at Cedars told me, you're a specialist, do special things no one else can do. What he meant by that was contribute to the team, just don't recreate the wheel here. Next slide. So what are the objectives for tonight? 3 of them: identify patients who may benefit from these interventional advancements. 2, understand broadly the new therapies so you can explain them to patients. And finally, just offer some suggestions on how to improve compliance with the CDC recommendations in regards to opioid prescribing habits. Next slide. So there are 4 big advancements. We'll go through each one. Next one, please. The benefits of the 4. So they're all minimally invasive, same day, no sleeping in a hospital bed, no need to staff the hospital. They're all done as an outpatient, take less than an hour, gets patients moving more, and then decreases opioid use. Next slide. What are the big 4? So this is the take home of the whole presentation. So the first one we'll talk about is the ablation of a nerve in the vertebrae. The second one is an interspinous spacer device. The third one is an ablation of the hip, the knee, or the shoulder. And finally, a spinal cord stimulator. Next slide. So I'm sure people out there have heard of some of these things. And what I wanted to bring up, this is a quote attributed to Taoism, is basically when the wrong man uses the right means work in the wrong way. So what am I trying to convey here? Those things that I just brought up and that I'll dive a little bit into deeper depth later on tonight. Basically, next slide, please. When they are used for the wrong patient, they don't work. That doesn't mean that they're wrong. So a further example to illustrate this is proper patient selection is paramount. So pairing the intervention with the patient is key. When you go out and get steak, I'm sorry to the vegans out there, when you go out and get steak, if you order a Coke or a Diet Coke or any other soda, the pairing is a little bit questionable. And I love Coke and I love steak as well, but I wouldn't pair these together, right? So where I'm going with this is we shouldn't pair together some of these big new procedures with patients that clearly will not benefit from them. So if you've heard of these procedures and there's not the best literature, maybe your friend told you anecdotally it doesn't work, perhaps it wasn't paired properly. Next slide. So let's jump right in to make this realistic. These are all real patients I've taken care of. So this is a 40-year-old male, chronic 20-year lower back history. It's dull and aching, it does not radiate. Sitting in the car makes it worse while he commutes to the west side for work. He's had a few epidurals, other pain physicians, but none of them really worked. He describes them as just temporary in nature. And he really does try to stay fit, but the pain has limited his ability to walk and work out. He's tried physical therapy, anti-inflammatories, muscle relaxants, and it seems like the popular one everyone's using is a CBD cream. He was given tramadol before, but really didn't find it to be helpful. And his last MRI was a year ago, and he was told it was unremarkable. So next slide, please. So these are the things that jump out to me when I get a patient like this. It's a younger guy, he's 40, does not radiate, so it stays in the area. Sitting in the car makes it worse. We'll go over this. He's had epidurals and they just don't work. He's tried a lot of good things, anti-inflammatories, muscle relaxants, so it's not a myofascial type picture. He's tried, the narcotic, still didn't help him. And his MRI, he was told, was unremarkable, but he wasn't shown the images. He wasn't gone over in detail what the MRI showed. So where are we going with this? Next slide, please. So this brings us to our first one, the ablation of the nerve in the vertebrae. That's a lot, that's a mouthful. So I like to say the phrase bone is home. And why do I say that? As you can see with the picture, there's a needle, it's a pretty thin needle, goes into the vertebrae, into the bone. It goes ahead and performs a radiofrequency ablation of the basovertebral nerve. Next slide. So who are the patients that might benefit from this? Lower back pain that does not radiate. That's a key question. Hey, does it run down your legs or does it kind of stay in the back? What percentage stays in the back versus run down your legs? Next one, the MRI shows modic changes. That's a key word, modic changes. They might say end plate inflammation, edema. There are certain ways to describe this. And then they might say, hey, pain is worse when I'm sitting in the car, not when I'm getting out of the car, just actually sitting in the car. Next slide, please. So let's talk a little bit more. The picture on the left, the breakthrough is why this is bringing tomorrow today. The breakthrough is before we didn't know that the nerves and the bones can generate a lot of the pain. Previously, we thought it was all about the discs, all about the spinal nerves, and that's a large part, but we overlooked the nerves and the bone. The middle picture this is describing the modic changes. So you can very easily see where the bones are damaged. I love bringing these up, talking to patients. They say, show me, and then you show them. A lot of them will take out their cell phone and they could see it very clearly. You see the modic changes. And the picture on the right is basically showing this nerve, or the needle goes into the bone, hits the nerves that reside inside the bone, and deactivates them. Simple as that. Next slide. What's the evidence behind this? Anything I do is evidence-based. So there's 2 level 1 randomized controlled trials. So that's the highest level of evidence. Average age is 50. Remember, the guy that I was talking about was 40. So these are younger patients. What did it show us? 50% of the patients had 75% pain reduction. The next point is really interesting. I never promise a home run to patients, but about a third of the patients in the study had 100% relief. So that's a home run, 100% relief. Now, 65% of patients resumed the activity level they had before the pain. 73% decreased their opioid use. And this was sustained over a 5-year period as well. Next slide. Moving on to case number 2. So this is an 87-year-old male, past medical history for multiple myeloma, hypertension, status post-CABG, AFib on Eliquis, and diabetes. His lower back and leg pain he describes as cramping and heavy. Pain does not go past his knees. Walking seems to make it worse. Bending forward when he's at Costco makes it better. And when he does stop, he gets some relief. And he also gets some relief with Norco. And his MRI shows stenosis. And he is unable to walk from the parking lot at Dodger Stadium to the stadium. And he says he does not want surgery. Next slide. What jumps out to me? This is an elderly gentleman, 87. His past medical history is significant. Multiple myeloma, CAD, status post-CABG, AFib, diabetes. He is not the healthiest person. Also key, the pain does not go past his knees. Does not go past his knees. Walking makes it worse. There's always a story. I gave you the Dodger Stadium. There's always a story that people will say, hey, when I'm walking around the park, I used to make it to the water fountain. Now it's to the second bench. And in a week, I'm afraid it's going to be the first bench. There's always a story connected here. And then the key point is he does not want surgery. He's 87. He's multiple comorbidities. He is not interested in surgery. So what can we offer him? Next slide. This is the Intraspinous Spacer, what I call the Doorstop, and we'll see why I call it the Doorstop. But next time you go to Costco or wherever you shop, you'll see people using the shopping cart sign. That's a dead giveaway. So the questions that you can ask to figure out if a patient may benefit from this: have they been told they had stenosis? It'll say that in the report. Are they not able to walk as far as before? And when they stop, the pain goes away. And very clearly, patients will offer this. They don't want surgery. They're not interested in any type of surgery. So let's talk more about the Doorstop, the Intraspinous Spacer device. So we all know stenosis means there's tightness between the bones. And basically, when patients lean forward, they open up that tightness. They relieve it. That's why they do it with the shopping cart. It makes them lean forward. It provides them relief. So the idea is, instead of giving them a shopping cart to walk around with, can we put something in their back that induces motion as if they were using the shopping cart? And you can see in the middle picture there, that's the size of it. It's really, really small. And it's a doorstop to open up the tight space. And I say it's a doorstop because you look at the picture on the left, is just like a doorstop, you can't push it past a certain point. It stops. You see that you put it in between the spinous processes, and just like a doorstop, it can be removed too. You literally turn it right to fasten it down. If you ever want to take it out, you just turn it left. Simple as that. Next slide, please. What's the data on this? So 90% of patients were satisfied at least 5 years. And why do I bold the 5 years part? This guy's 87. A lot of patients who are older who don't want surgery, they say, hey, how long am I going to be around? Well, the data shows us 5 years, 90% of patients are satisfied. Next slide. Does it help with leg pain and back pain? We'll see here. 75% of patients had improvement in leg pain. That lasted 5 years. So the patients who say, yeah, I got an epidural, didn't work. Yeah, I got an epidural, it worked 2 weeks. Well, We have a device here. 75% of the patients said it lasted to help their leg pain 5 years. That's significant. Next slide. And the big one for me as a pharmacist, 85% of the patients had a decrease in their opioid usage. Next slide. And quick break here. Any burning questions so far? There will also be time at the end as well if there's no questions.
The way you can answer questions or ask questions also, there's a chat or Q&A bar. You can just type it in at any point during the presentation, and I can kind of facilitate that at our breaks or at the end. We have one, Dr. Orlovich. So biomechanical changes, contraindications with the spacers.
Yeah, great question. So what are the contraindications for a spacer? If someone has a DEXA scan that suggests they have very brittle bones, osteoporosis past a certain point, it would not be wise. If there is slippage of one vertebrae upon the other past a certain point, it would not be wise to do that as well. If there's any instability that's significant. The data, Rachel, correct me if I'm wrong, the data I believe was in BMI of 40s as well. So there are some who believe if the patients have BMI that's far too large, it wouldn't take that as well.
That is correct. And then we have another one, minimally invasive surgery with the spacers, question mark.
Yes, so this is, if I'm understanding correctly, is it really minimally invasive if you're putting a doorstop in between someone's vertebrae? I totally hear you. The incision is very, very small. People, it's a same day surgery as well. It's going to be a very small incision. They go home the same day. I know there's some physical therapists listening as well. So when they do go home, there's still precautions to take it easy, 6 to 8 weeks, gentle, kind of return to activity. They come back into the office as well. No turning, lifting heavy things as well. But this is considered a very quick procedure. They're going home same day.
Beautiful. I think that's all we have for now.
Great questions. Next slide. So this is something to break up the monotony. So I was talking to a patient the other day and she's like, hey, can I tell you something? And I was like, sure, what? And she's like, I don't like opioids, pain pills. I'm like, all right, me neither. And she's like, have you seen the documentary? And I was like, what documentary are we talking about? And she's like, it's called Dope something. And I was like, do you know the name of it? And she goes, well, it's like Dope Nation. So I turned to the computer and I typed in Dope Nation. And I was like, you mean these two rappers from Ghana? And I looked at her and she was like, oh, no, definitely not. So if you go to the next slide, she wasn't talking about Dope Nation. She was talking about Dope Sick. And whoever produced this show, they're great. They're going to get a ton of thank you cards from me because they are basically, from what I've heard, I haven't seen the show, but they are telling the people kind of just how terrible opioids are. And we all know about the addiction, but when you tell patients like, hey, it will actually cause you more pain than before, or actually it will decrease your testosterone, your energy levels, your sex drive, all these terrible things patients don't want, that gets their attention. So that was just a little break. Dope Sick, if you haven't seen it, I heard it's great. Next slide. Alrighty, case 3 of 4. 57-year-old female, past medical history, depression, anxiety, fibro, breast cancer, chronic left shoulder pain. So she was seen by an orthopedic surgeon, said, you're not a surgical candidate. And she has on a question, or 2 papers of questions she'd like answered. Her range of motion is mildly limited, not terribly. And she says she doesn't like medication, but she wants to swim. Next slide. So what jumps out to me with this one? These are the patients that can be challenging, that need some resources sometimes, but they're great patients if you provided the right resources. And that's patients with depression, anxiety, fibromyalgia, has a rough go with breast cancer. She's not a surgical candidate, so she's not getting surgery. Range of motion is mildly limited. She doesn't want to pursue medications, but she wants to be active. She wants to swim a little bit. So what can we do for her? Next slide. And that is the ablation of the shoulder, hip, and knee. These are the burning of the nerves. I put a little grill there. I hate the term burning of the nerves, so I always say deactivate or turn off. But a lot of patients will say rhizotomy or burning, and I'm like, yes, that one. And on the left, it's a grill, obviously. On the right, that's what we use to burn the nerves. So you see just how thin those needles are to accomplish this. Next slide. All right, so what about burning of the nerves? What are some of the characteristics of the patients who might benefit? The patients will say, I don't want surgery of my hip, my knee, my shoulder, or they've had it and you see them as a physical therapist and they're just plateauing. You're not able to go any further. Do they still have some pain after surgery? Did they say, hey, I got the cortisone shot, I got that gel shot, and it lasts a little bit, but it just doesn't work? Or are they just too young for a joint replacement? These are some of the patients who might benefit. Next slide. All right, so let's talk about burning of the nerve. So how exactly does it work? It's radioactive waves. It activates adjacent molecules. It temporarily deactivates the pain signal. So it kind of disturbs the transmission of the pain signal. Important to note, it is not permanent. Once again, the radiofrequency ablation, the burning of the nerves, it is not permanent. And this is something I commonly get asked, is my motor function going to be affected? It should not be affected. Why do we do that? Theoretically, yes, there's a risk. However, we use fluoroscopy, we use x-ray to make sure we're in the right spot. Secondarily, we do a test before we always burn on a separate day. And third, we will actually try to elicit a motor stimulation. So if we're around a motor nerve, if we're around somewhere we're not supposed to be, we will see the body move, the limb move as well. So there are multiple steps to ensure that there's no motor weakness from this. Next slide. So let's talk a little bit about which nerves that we'll be hitting with the ablation. So in the shoulder, lateral pectoral nerve, suprascap, and axillary. The hip, the femoral nerve, and the articular branch of the obturator nerve. And finally, the knee, the medial superior, lateral superior, medial inferior genicular nerves. And this slide I think is really great. So when people say, I had the cortisone shot, I had the gel shot, it doesn't last too long. With the burning of these nerves, we can see relief 6 to 24 months. So that's significant relief. Next slide. Let's jump into kind of the literature, the evidence behind it. Let's start with the knee. So compared to a steroid injection, the radiofrequency of the knee is 4.6 times more likely to have relief at 6 months. Number needed to treat is 2. So basically that means we have to do this in 2 patients for at least one of them to get relief. So that is an outstanding number, in my opinion, to get relief. We'll talk about the medications, what their number needed to treat is. It's not 2. 1 in 5 people had 100% relief in 6 months. Once again, this is a home run. I'm not going to guarantee 100% relief, but 100% relief is a home run in 6 months. Moving on to the shoulders. Shoulders, basically people say, how will this work? How do you know? Suprascapular nerve innervates 70% of the shoulder. So we're going to get that nerve. People say, yeah, but what are the indications? I have clearly frozen shoulder, but do you think it'll help me? And it does help with frozen shoulder. And then compared to the cortisone shots, improve long-term relief. And finally, the hip, we see that about 100% of patients had a decrease in their opioids. They're walking better, they're sleeping better, activities of daily living is better, and their pain scores go way, way down as well. Next slide, please. Moving on to the 4th case. So this is a retired, this is a real patient here. Retired 63-year-old male, former police officer, status post 3 lower back surgeries, presents with lower back pain. When questioned, he says the majority of his pain's bilateral legs and not actually his back. And he's frustrated. He can't lift weights. He can't go to the gym. He would like to move to Florida, but he can't because of all this pain that he's in. He had an EMG recently, chronic L5 nerve injury, and the spine surgeon said that he would not benefit from surgery. Now, the surgery that he had before, hardware is seated well. He's tried the opioids, tramadol, oxycodone, Percocet. He just didn't like the way they made him feel. Next slide. What jumps out to me? 3 lower back surgeries. So when you get patients and they're like, hey, I've had a surgery here, had a surgery there, had a surgery right there, your ears should perk up and say, hey, maybe this patient can benefit from if they've had multiple back surgeries. Also key, if it's bilateral leg pain, not back pain. So the surgery in the back fixed the back. However, residual leg pain, this is what we're going to be tackling. Next, there's no further indication for surgery. Surgeon doesn't want it, patient doesn't want it. And finally, the patient is fed up with all the opioids, doesn't like the way they make him feel. So what can we offer this patient? Next slide, please. The spinal cord stimulator. I will dub this one the rubbing of the toe. And the lower left, those are the leads that are put in the patient. They're very, very thin. That's, I believe, a quarter to show you scale. And this is what I always tell patients. I always tell them, you can try it before you buy it. So let's jump into this a little bit. Patients who have diabetes and burning leg pain, they may benefit from a spinal cord stimulator. Just like that gentleman we talked about, they've had multiple back surgeries, still has pain in the legs. Some patients come to you with a diagnosis. They say, I know I have complex regional pain syndrome. I know I have RSD. If patients, even for the lower extremities, the upper extremities, burning and tingling in their arms as well, we start to think, hey, can they benefit from a spinal cord stimulator? Next slide. So what's the whole deal with me calling it the stub toe? Well, this is a question I always ask the patients. And I say, look, when you were a kid, what did you do when you stubbed your toe? Probably like everyone else, you rub it. We're all familiar with this. So I said, look, conceptually, you already know how spinal cord stimulation works. And they kind of look at me like, what? And I say, look, when you stub your toe and you rub it, the brain can only accept one signal from the body. So the rubbing sensation is faster and it beats out the pain signal that goes to the brain. So the pain signal is essentially shut out and the brain lets in the rubbing signal. And that's the gate theory, 1960s seminal work that was proposed. Try it before you buy it. The best part of this procedure, I feel, in my personal opinion, is you can try it for 7 days. So basically you put in an epidural, you send the patient home, you say, hey, did you like it? How much pain relief did you get? What were you able to do? They come back to the clinic and they just lean forward and there's a little epidural wire, very thin, sticking out. They lean forward, you just pull it out. It's that simple. And if they like it, then we can go in another day and we could talk about implanting something into their back. It's very small. You'll see it in a second. If they don't like it, that's it. They lean forward, the leads are out, and we gave it a good shot that are the best evidence that we have. Next slide. And once again, this is really key. So I was talking about it, the gate control theory, 1960s. The pain speed, when it goes from whatever area is painful to travel up to your brain, that is slow, like a leisure walk upon the beach. The rubbing signal, either you're doing it mechanically or the lead from the spinal cord stimulator is doing it. That's the rubbing speed. That rubbing speed is like a really fast car. That's going to go to your brain first and beat out this leisurely slow pain speed. Next slide. And these are some pictures to show you I talked about the generator, the battery. So there's a little lead, a little wire that connects to the battery. The battery is pretty thin. Everyone's got enough space in the lower back to put that in there underneath their skin. A patient I had today said, oh, it's like a pacemaker. I was like, yeah, that's basically kind of the similar idea. The cool thing about this is you can change the modes of the tickling or the rubbing however you want. It's all wireless from a phone. So they come back to clinic. You don't have to open them up. You just have an iPad, special iPad. They have a device. You can change how often, how much it's rubbing the nerves. Lots of different modalities. There's a lot of science behind it. A lot of really smart people who are working on this. That's really neat. And finally, the last picture, it can be removed. Those wires, the little battery can be removed very easily. They're very, very thin. So it's nothing that's permanent. Next slide. We're going to switch gears a little bit. We're still going to stay on spinal cord stimulator, but the hot topic in pain medicine is using this for patients with painful diabetic neuropathy. So patients with diabetes. Where did this come out? JAMA Neurology back in April of this year proposed a new mechanism for using spinal cord stimulator for patients with painful diabetic neuropathy. Next field. But before we talk about that, how do we currently treat diabetic patients who have painful diabetic neuropathy? These are, according to numerous guidelines, the first line treatments. Sure, we've all heard of them. Gabapentin, Lyrica, and Cymbalta. These are the gold standard first line treatment therapies. Next field. So what's the problem with these medications? The gabapentin, the Lyrica, the Cymbalta. Next field. The problem is at 6 months, more than 60% of these patients on gabapentin or Lyrica stop taking the medication. And the majority of patients don't switch to one of the three other ones. So 60% of patients at 6 months aren't taking them and they're not switching. So are they getting relief? Highly unlikely. They're not taking anything. So enter spinal cord stimulator. Next field, please. So this is something I talked about number needed to treat. Remember before I said number needed to treat for burning of the knees? You need to see 2 patients for one of them to see relief. So the lower the number needed to treat, the better. The higher the number needed to treat, the less efficacious the therapy is. So between 6 to 7 patients have to be treated, had to be given gabapentin, Lyrica, or Cymbalta for one patient to find relief, right? So when we prescribe the medications, we have to see 7 patients all prescribe that medication, and one of them will see relief. So the joke is, do you feel lucky? Next slide. So what is the data of using a spinal cord stimulator for patients with painful diabetic neuropathy? So after 6 months, we're looking at the left, the boxes that aren't shaded. So patients had a pain score of 7 out of 10, and it went to 7 out of 10 to 6.9. So no change as to be expected. If we put in the spinal cord stimulator and put the patient on medications, after 6 months, you see a drastic decrease from 7.6 to 1.7. Next slide. And how about the improvement in pain? So what percentage of patients get more than 50% relief? Only 5% of patients get relief with medication. Once again, I'm a pharmacist. I really enjoy pharmacology, but I am knowledgeable enough to say, look, there are limitations to the medications we prescribe. However, with the medication and the spinal cord stimulator, almost 80% of patients, 8 out of 10, get 50% relief. Next slide, please. Are patients satisfied with this? I'm obviously believe it's great therapy, but it doesn't matter what I say, it's what the patient says. 92% of patients are satisfied or very satisfied getting a spinal cord stimulator in this trial for their painful diabetic neuropathy. Next slide. This is something just to break up the monotony before we move into the last section. This is pretty common, and this is a patient, like a patient I treated before. It's not the patient, but we put these spinal cord stimulators in, and patients, they become overwhelmed with joy. They said, wow, I'm in no pain, or this is amazing. And they're so happy. And then you see the mood just change sometimes. And this isn't scientific, this is purely anecdotal. The mood changes, and they kind of get angry and upset. And they said, basically, why didn't anyone tell me about this before? And then they're like, oh, I missed this birthday. I didn't go to this wedding. Oh, I could have driven down to San Diego with my husband. All these things they go through in their mind, things they've missed, and they wish they would have had it before. So that's what drives me to give this presentation. And thank you again for taking your time to listen and educate yourself about these newer therapies. It's for patients like this. I don't want to hear patients say that anymore. I'd rather have patients come in and say, hey, my friend got this. I'm ready to improve my functional activity. How can we best do this? Next slide, please. So real quick, just a recap of the big 4. Ablating the nerve in the bone and the vertebrae, and that's the bone burner. The interspinous spacer, and that's the doorstop for the stenosis, the people that are bent over with the shopping cart sign. The ablation of the hips, knees, and shoulder, that's burning of the nerves, self-explanatory there. And finally, the spinal cord stimulator, and that's the stub toe concept. Next field, please. And this is finally for the people listening. This will take us towards the end, but basically recommendations, how to best treat chronic pain patients in the primary care setting. And I fully acknowledge that I have the luxury of focusing on one problem. And I also have the luxury of trying not to cover all the problems in 15 minutes. So my situation is a heck of a lot easier, and I recognize how challenging it is for listeners out there. So thank you for doing what you're doing. I appreciate it. Next field, please. There's a lot going on with this slide. It's basically recommendations for chronic pain patients, just general tips. Generally treat depression and pain at the same time. If you're talking with the patient, and obviously if you feel down, chances are the patient might also carry a diagnosis of depression. The great thing is some of the medications we can treat depression and pain, such as Cymbalta. Setting clear expectations is very important. I had a patient say, look, this has been going on since 1977. I say, it's not going to be fixed overnight. Let's take baby steps here. This one I really, really like. Ask them if they'd like to come down on their narcotics. There was a study from Beth Darnell up at Stanford, and she references up to 40% of patients said yes, they'd be willing to come down. And in my experience, it seems like some of the patients equate pain pills as the only thing for pain. And you and I both know there's lots of different options out there. So I've been surprised asking patients, hey, are they working? Are these pain pills, do you like them? And the study shows about 40% of patients would be willing to come down or off those medications. Next, focus on functionality, not the pain score. We all know that by now. I alluded to this earlier. Tell patients, hey, the narcotics will give you more pain than they take away. And that's a concept of hyperalgesia. Next, obviously, I'm practical. Some patients need some opioids for short-term acute settings. Start with tramadol if necessary. Combine that with multimodal agents, so Mobic or Celebrex for your anti-inflammatories. Or patients who are older or renal problems or bleeding issues, Voltaren gel 4 times a day, decrease systemic absorption of the NSAID. Xanaflex is my personal favorite for muscle relaxants. Really helps if a patient has a component of anxiety. Chances are they haven't had that medication as well. And this one, I tell all my patients, Tylenol, Tylenol, Tylenol. They say it doesn't work, but it really helps with the central sensitization of the pain. So it prevents the long-term effects of pain really well. Personal recommendations, I would try to steer clear of codeine. The way people metabolize codeine is very erratic. Stay away from soma, it's addicting, and then lesser degree of Robaxin. You have to take more and more, and there's a chance of people becoming addicted there. If patients want something because they want to feel sedated, Flexeril or Baclofen will go ahead and make them sedated. They're not addictive. I love this one here. Just have a knowledge of 3 medication management experts in the area, people who have the team and have the resources to manage the medications. This one's really big, treating sleep. People think they need to go up on melatonin. You actually need to go down. It's counterintuitive. And for the people who are always worried about, oh, did I do enough of a workup? Don't worry about that. In an ideal world, get them working in physical therapy, get them connected, get an x-ray to see generally what's going on. If you get none of those, it's fine as well. Next slide. And we're finishing up here. These are the best practices from the CDC. Document the 5 A's. Analgesic. Is it working? Are they doing any activity? What's their activity level? Adverse effects, constipation, somnolence, fatigue, affect. Did they seem off? Avoid use of benzos. It's really, there's a lady who just wrote a book. It's coming out. This is the next wave of addiction in our nation. It's the benzodiazepines. So really try to avoid benzodiazepines and opioids. It's just a very terrible combination. In terms of practical advice, keep the morphine milliequivalents, MME, to less than 50 or 90. So what does that mean? 3 of the Norco-10s is going to be 30. 100 milligrams of the tramadol twice a day is going to be 20 MME. Percocet 10 twice a day is 30 MME. So it gives you a general idea. And then if starting any medication, see them in 4 weeks. So see how they're doing. And finally, check cures. That's the database in California. And the biggest thing, if someone else wrote it, doesn't mean you're obligated to continue writing it. You obviously reserve the judgment each time they come in to see if it was an appropriate prescription as well. Next slide, please. So this takes us to the end of the talk. Hopefully the Dodgers had a better year, but oh well. But that's my take-home message. Let's go and hit some home runs. Next slide. And these are the citations if anyone wants to see the evidence. Next slide.